Hi, I'm Mike Kontos, editor for the CardioSource biomarker website here in Chicago at the American Heart Association Scientific Sessions. Today I have Dr. Steve Lipshultz from the University of Miami, who presented some interesting data from a multi-center trial that looked at 3 different biomarkers that have traditionally been used for risk stratification and prognosis in patients with acute coronary syndrome. Instead, they were used in an entirely different setting, patients who are undergoing treatment for acute leukemia. Steve, can you tell us about your study?
Sure. So one of the issues that we face in childhood cancer is that we have children that more than 80% now become long-term survivors of childhood cancer. But when we look at them 20 or 30 years out, they have more than an 8-fold increased risk of cardiac death and late heart failure at 15-fold higher rates. And it becomes important to us, how can we take these otherwise healthy children during therapy and identify who is at greatest risk for cardiotoxicity from chemotherapy and have that persist. So in this particular study, we had a dozen centers around the United States and Canada that took children that had high-risk acute lymphoblastic leukemia that were receiving doxorubicin, adriamycin chemotherapy. We obtained serially during therapy cardiac troponin T, NT-proBNP, and HSC-reactive protein. And we followed these children many years after therapy. On an average of almost 5 years after therapy, what we found when we were unblinded to the results of this prospective study was that the children who had cardiac troponin T elevations, and the height of these elevations were not at acute myocardial infarction levels, relatively low levels. The children that had these elevations during anthracycline therapy, many years later, were the ones that had inadequate left ventricular wall thickness, reduced left ventricular mass for the size of their body, and more concerning and more ominous was that they had evidence of early left ventricular remodeling. We also found that for the children that had NT-proBNP elevations during the first 90 days after diagnosis with cancer, they also had many years later a significant association with left ventricular remodeling. And so what this said to us was, if we are going to try to identify during therapy, active chemotherapy, biomarkers that are validated as surrogates against late echocardiograms, which in turn have been a useful surrogate for who would then go on with further follow-up to get congestive heart failure or later pump failure, we now have cardiac biomarkers that are validated as surrogate endpoints against late abnormalities on echo. And this enables us to then use that to test strategies to try to prevent or reduce subsequent left ventricular remodeling.
This seems consistent with other studies. I'm wondering if we're getting to the point where we should measure these biomarkers, particularly troponin, in patients undergoing chemotherapy?
It's an excellent question, and the real issue that we care about in childhood cancer is the definition of successfully treating cancer historically was 5 years after therapy, was there event-free survival? That's oncologic efficacy. We now, because 80% of childhood cancer patients become long-term survivors, have changed the paradigm. Successful treatment of childhood cancer is the balance between oncologic efficacy and toxicity and late effects. And so the next stage for this is, yes, we should measure these during therapy in the setting of research protocols and be determining whether responding to cardiotoxicity in the global picture of the balance between oncologic efficacy and toxicity and late effects results in better quality of life in survivors of childhood cancer.
Thanks for that discussion. I think this provides yet another area where cardiologists are going to be collaborating with other specialties, much like we do with renal doctors. We're now going to be collaborating with oncologists to help prevent the long-term effects of patients who survive cancer who ultimately may end up in our care needing treatment for heart failure. This is Mike Kontos from CardioSource website. Thank you.